he has no past illness. He had a complex tibia fracture with an open wound. Next. So the initial treatment was he was put on a temporary external fixator. Quite a good job being done, but you can see there's some amount of bone loss there. Next. So he was referred with this kind of picture. You can see the bone jutting out. Next. So this is a zoom photo. You can see the bone and the wound is definitely, you are not very happy with the current presence of wound. Next. So next. So you can see on the plain radiograph, extension of infection has gone through the proximal and distal part of the tibia, and in the AP view you can see possible sequestral osteomyelitic changes as well. Next.
How long he kept the patient?
Almost 6 weeks to about 2 months, so close to 2 months. So you see, so when he was referred, it's already, infection has already settled in. Okay, we shall go back to the fate of the patient later. So to begin with, fracture fixation via Ilizarov is just a part of utilizing Ilizarov. Of course, Ilizarov are being used for other cases as well. So in Basse's classification, it is a collective function of, we use it for, Ilizarov are being used for acute fracture fixation, bone transport, bone lengthening, correction, deformity, and the whole list of it. So next. So the advantage, before we go into the indication, the advantages, like what being explained by other professors before, it is a modular design. So it is like Lego. We fix on various patterns of fractures. So it had the circular nature of the frame, enhanced stability, and with Ilizarov you can allow the patient to early weight bear. It is most of the time is minimally invasive unless if you do larger bone resection. So of course you need to do some of the bone resection and wound debridement and so on, but most of the time it's minimally invasive. And then it holds fragment when traditional fixation not feasible, meaning that if it's not plateable. Alright, next. So these are the long list of indication. We'll begin from periarticular fractures until periprosthetic fractures. Next. So for severe periarticular fracture, you can see that this kind of fractures, you encounter this in your practice. Severe periarticular fractures, so you know that sometimes when you assess the CT scans, it's not plateable, or the condition of the soft tissue is not feasible for you to put internal implant. So you sort out to Ilizarov. Next. So yes, of course, you put something like this. This is, for example, of a very smashed distal femur. Also, we will try to apply Ilizarov. So the fact is that the goals of doing Ilizarov in these patterns of fracture is because you want to achieve some articular congruency. You want a reduced joint so that you can restore early motion. And then things that we tend to forget is that you want to restore the mechanical axis, especially for the lower limbs. Upper limbs is a bit more forgiving, but for the lower limb, apart from doing a good job trying to piece out all the bones together, you have to restore the mechanical axis. And finally, you want fracture consolidation. This is a simple diagram to show if, let's say, you are doing Ilizarov for a femur. So it is less forgiving for a femur because, like what being shown before, a good amount of ring you can apply on the distal femur. Because of the larger surface area, you can apply for about 270 degrees around the distal femur. But you go a bit more proximal, it is probably you can apply pins and probably from anterior to about halfway through the posterior side of the femur. But on the medial side, is hardly any pins can be put. So a paper from Balog 2020 says that for periarticular fractures, you can provide excellent clinical outcome and early mobilization with Ilizarov. And then another paper for complex distal femur that compared between Ilizarov and double plating. So the function-wise, Ilizarov allow earlier weight bearing and less blood loss compared to double plating. So what else can you apply for Elizarov? So fractures associated with severe ligamentous injury. Mind you that when you had periarticular fractures, either for upper limb or lower limb, so you must consider the fact that the ligaments will be injured as well. There's no point fixing the tibia nicely, but the patient can't walk with an unstable joint. So you will fix an Elizarov in this case as well. So the goal in that particular case is that you want a reduced joint, you want the patient to be mobile during fracture healing. Of course, you want fracture consolidation, and furthermore, you want to achieve ligament reconstruction later in a reduced joint. Alright, for example, this is just an example that we fix a complex femur fracture, tibia fracture with multi-ligament injury, so patient can at least be mobile even with an unstable knee. Other conditions that you will fix Elizarov is for those patients who had vascular injury. For example, this is a paper done by Giordano 2021 that they did a limb salvage, they did a popliteal bypass for this patient with a temporary external fixator. Then, this temporary external fixator, then they fix it in Elizarov for limb salvage. So the goal in these conditions are actually the goals in that particular case was limb salvage. So they want to fix an Elizarov to get minimal disturbance to the vascular repair. They want to prevent implant-related infection because even if they put internal implant, they get infected. So the patient is always mobile on Elizarov, and finally the goal is to get fracture consolidation. So the next condition where you will apply Elizarov is open fracture with severe soft tissue injury. This is, I think, almost you will see this in your practice. Open fracture with severe tissue loss. Sometimes the knee is open. Sometimes the knee is open, so you apply Elizarov. So in this particular photo example, the goals of the treatment is to have a stable fixation while the soft tissue heals. You want to modulate, or you want to plan your Elizarov so that you have an accessible area to do a comfortable regular wound dressing, prevent implant-related infection, make sure the patient is always mobile on the Elizarov, and finally fracture consolidation. Another paper by Takeshi So this paper, they did an Elizarov with a muscle flap. Next. So there's a severe combination of the foot. Next. So they did a tissue flap with Elizarov. So the challenge here is that they are doing the Elizarov through the muscle flap as well. So ultimately, they managed to get a heel bone and heel flap, early weight bearing, and eventually get a primary arthrodesis of the ankle. So it's a successful case. Next is condition where open fracture with bone loss. You can see that they are severely fragmented distal femur. This is I want to show you a thought process actually. So you can see a severely combined distal femur, a bone gap, and most likely there will be some soft tissue injury as well. So with this kind of pattern of injury, if you fix an Elizarov, so the goal is actually to have a stable fixation. You want to minimize soft tissue manipulation. You want to preserve the viable bone stock, right? Then again, mind you that you want to maintain and restore the mechanical axis of the lower limb. Then you need to plan and manage the bone gap, most likely by bone transport or mascale or other methods of managing the gap. Then finally, you must make sure the patient is always mobile on that particular Elizarov. This is a photo courtesy from Mr. Kamarulha from Klang. This is a very interesting case that the patient had you can see the entire distal tibia was smashed and out of the body. Alright, so this is not an easy case or journey to embark. Alright, so what I want to show you is that you have to have a problem list. You have to gauge how much you can do for the patient. Of course, amputation is a simple decision, but if you want to, the immediate problem is that whether you want to do limb salvage or amputation. Neurovascular compromise, you have to assess the compromise, if any. So there will be large soft tissue injury, large bone loss, segmental fibula as well. So the future problem, if you were to decide on limb salvage, you have to understand that definitely patient will require bone transport. You have to consider that the large transport will have soft tissue invagination, and then you have to understand that there is no more distal tibia. So you will be docking on the talus, so definitely you have to counsel the patient that eventually patient will have a stiff ankle because they will have a tibio-talar fusion. So the rest of joint contracture and so on. So whenever you have a difficult case, don't get alarmed. You just have to list down the problem and tackle the problem one by one. So you have to ask Mr. Kamaro what happened to the patient. Next. So other patient.
We removed it already.
So fantastic results. So we also, besides another indication for Ilizarov is that you are performing Ilizarov in a closed fracture with compartment syndrome as well. So this paper by Key et al. Use Ilizarov for compartment syndrome for 30 patients. So finally they managed to restore the joint function and have fewer complications. So it's a safe and effective method for compartment syndrome as well. So fragmented unstable fracture, I'm sure that you have encountered this in your practice. Ilizarov is a method of choice as well. So the goal in a segmental fragmented fracture is to have stable fixation, minimal invasive, restoration of axis, mobile patient, and fracture consolidation. So you can see that there are a repeating pattern of goals here, right? But it's always good to repeat so that these things goes at the back of your head, right? So of course another paper says that it is a minimal invasive, multi-level stability, excellent unit time, and good functional outcome in a segmented fracture. Again, the last indication is periprostatic. I hardly encountered this, but this has been published in some papers as well, where you do circular or hexapodal treatment for periprostatic fractures, and my concern is usually prosthetic joint infection, but they have good results with this as well. These are the results after periprostatic fracture. The final paper by Nozaka et al. Also discussed on IEF on periprostatic fractures. So they have good results as well. So the last part is the limitation. There are a long list of limitations. There are complications as well, but will be explained by another surgeon. So, but the limitation that you will encounter doing Ilizarov, the first one is understanding the safe zone. So not every Tom, Dick, and Harry can do Ilizarov, but with understanding the safe zone is paramount, because you have to understand that learning curve is a bit steep. So aberrant anatomy, you have to understand that sometimes not every anatomy is the same, especially when you have gone in with a flap, for example. So you have to understand that the panicles will be going through, so you have to plan your Ilizarov, where the wires go through and all. So next. So imagine that this is a smash distal humerus. So the vessel will be going everywhere, the nerve will be displaced. So putting Ilizarov in this pattern of fractures is very challenging. Next. So abdominal soft tissue, this is not uncommon. You'll encounter patients with a very, very huge thigh or leg. So putting Ilizarov is not easy. It comes with a price as well. Bulky hardware. So in the beginning of my training, we tend to put Ilizarov for the whole limb as well, femur, tibia. So you can see how bulky it is. But nowadays we are trying to move towards maybe a hybrid system, even with the LRS, with the hybrid system meaning the LRS for the femur, or LRS for the femur and tibia, or tibia and Lazaroff for femur LRS. Of course, alright, this is industry related, yeah, so it's expensive. So you have to have a team. If you are in a district setting, you have to understand that you have to train your team, and then you have to have a complete Ilizarov set. Doing Ilizarov is with poor devices or incomplete is very challenging. So you have to train your paramedics and assistants to have to smoothen the procedures of doing Ilizarov. So like I mentioned, this is the training and doing again and again. And having a team which is scrubbing with you regularly helps a lot. Next. Alright, pin site infection, protruding pins are the challenge here. Alright, sometimes if you don't do it well, it's not on the clothing. Patients will be uncomfortable with exposed pins and wires. Next. Pin site infection, another concern. Next. Joint contracture. Of course, the limitation is that if you don't do it well, patient end up with all these contractures. So you have to do further procedures to deal with the joint contractures. Regular physiotherapy and family support. I think we are going towards more uncommon but important. You have to advocate physiotherapy, move the patient, have family support for those patients. Next. So aesthetics, not very convenient to have bulky devices protruding from your pants or from your arms. Alright, this is less being talked about but very important. So I've been trained by my SIFU and my teachers that always mobilize this patient on Ilizarov. Alright, this is very related, not being taught well but very related, mobility and emotion. So I always tell them that patients who are in low mood will get immobile, get immobility, cause muscle atrophy, and then it's a vicious cycle, So the way to break this vicious cycle is always to make your patient mobile. Fix the Ilizarov, don't sit them. Fix the Ilizarov today, move the patient tomorrow. Alright, now we come back to the fate of this patient. So the issue is that when the patient was being referred initially, they just discussed about the exposed bone, but we noted that the patient started to have contracture for the knee with this exposed bone and knee contracture. So infection. Alright, so let us list the problem. So we have a large area bony osteomyelitis that will definitely result in a large bone resection and a right knee joint contracture. So in the beginning, the initial planning was, this is my regular drawing. I was being taught by my teachers to draw and plan. Right, so this is the initial planning just for the tibia. However, in view of the knee contracture, so we had to do this. Boleh klik tak? Move forward. So unfortunately, this is a video showing that alright, never mind. It's okay. So anyway, this is the intraoperative finding. So you can see that this is the knee contracture device being set up. So this is the tibia transport being planned. So the resection was quite long, almost 10 centimeters of resection. So there was a nice video, unfortunately, never mind. So this is the intraoperative construct. So it was constructed in a bent position because the knee was bent in this position. So the first area that you see here, the green line showing the construct to get a conventional correction from the knee, gradual correction from the knee. This was being taught during my training in Kelang with Boss Dr. Haq. So this was applied here to deal with the contraction, and the other long segment here. So this is the The green one is the gradual correction of the knee. This is the motor being done for the knee, for the gradual correction. This is the purple line is actually a combination for the tibia bone loss transport. So this is the motor to perform the distal to proximal transport. So this is the initial immediate post-operative images. Next. So this is a couple of weeks after the gradual correction being started. Next. So this is at the end of the gradual correction of the knee. So we managed to get a full extension. So but the tibia is still midway. Next. So this is at the end of treatment. So managed to dock the tibia nicely proximally. Next. Alamak sayang. So actually there's a video showing that the patient is walking actually. Can you go next? So it's a journey of having from the moment the patient was referred, the resection, the transport, and finally the bone transport. So, can you request access? I want to show you the final result. Tak boleh? Request access. Sorry, give me a second. The request. Sorry, give me a second. Okay, click again. You go back again. So this is the final result. This was taken last week. Play. So this is at the end of the treatment, okay? Patient is happily walking, patient is mobile, smiling inside the mask. Alright, so, alright, thank you. Alright, so in conclusion, Elizarov surgery is to salvage a limb is a journey for both the patient and the surgeon, okay? So it takes a whole, it's a long journey. So you have to understand the whole process to make sure that the surgery is worthwhile for both you and the patient. Alright. So most importantly, they must comply to rehabilitation, make sure the patient is mobile, and patient is happy, towards along the process of surgery. Okay. Right. With that, I end my talk. Thank you very much.